Welcome to Atrium Health Navicent Knows Health. I'm Cindy Busby and I'm here today with Dr. Richard Thomas. He's board certified in orthopedic surgery and also in sports medicine, and today we're going to talk about his practice in Central Georgia. Dr. Thomas, thanks so much for being with me today.
Thanks for having me.
Would you first tell our audience a little bit about the role of an orthopedic surgeon, so all of the areas of the body that you can operate on?
Orthopedics is essentially looking at the musculoskeletal system of the human body, and when we say that, we're talking about muscles, tendons, joints, bones. So we take care of fracture work, arthritis, tendon injuries, things like that. And then we also, orthopedics encompasses taking care of spines and neck and lower back, and so it's pretty all-encompassing. I mean, our body is full of all of orthopedics, really. I mean, bones, joints, muscles, and tendons.
And when it comes to specializing in the area of orthopedics, what have you decided? I know you can be a generalist, but what are some of the things that you work on specifically?
Yeah, I mean, as I've been practicing for about 15 years, and at first I would take care of anything, but my area of interest is really in the shoulder and the knees. I do about 50-50 for both of those joints, and everything from arthroscopic surgery to reconstructive surgery, such as total joints and things like that.
So today, let's talk a little bit about shoulders. Can you tell the audience first a little bit about the anatomy of the shoulder? Because I think people think it's just one thing, but there's several pieces of it that can actually be damaged or need repair. So can you talk a little bit about that?
Yeah, I mean, shoulder pain is one of the most common orthopedic problems we see, and it can be caused by a lot of different pathologies. But the shoulder joint is really, it's kind of a ball and socket, and what's unique about the shoulder is there's so much motion in the shoulder compared to most joints. If you think about the knee's almost like a hinge. It just moves in one direction. The shoulder moves in all sorts of directions, circular and forward flexion, abduction, all kinds of motions. So because of that, it can be a little more unstable, and the muscles and tendons around that joint can be damaged easier. And there are a lot of things that can cause pain around the shoulder, not just arthritis where you have wearing away of the cartilage, but also everybody knows about rotator cuff injuries or rotator cuff tears. That's a tendon that is attached to a muscle that can get worn away and tear and cause a lot of pain. So there are a lot of different pathologies in the shoulder and a lot of different ways of treating those pathologies.
So let's talk a little bit about treating some of those. So when you talk about shoulder replacement, can you tell us a little bit about what types of conditions people come in? So you mentioned some arthritis or maybe an injury that they don't recover from. And then what is replacement like and the techniques you use?
Okay. So the main reason for doing a shoulder replacement is arthritis. And what arthritis is just wearing away of the cartilage that leads to pain and inflammation of that joint. So like I said, the shoulder joint has a lot of motion, but it's basically made up of a socket and a ball. So ball and socket joints, sort of like the hip, except the socket is extremely shallow compared to the hip joint, which has a very deep cup. Because of that, you can have some instability of that shoulder, and but essentially replacing the shoulder means that we replace the socket with a plastic socket, and we replace the ball with a metal ball. That's a conventional total shoulder. We do, when we see patients who have chronic rotator cuff tears or really bad fractures, we sometimes have to do a special type of shoulder replacement called a reverse shoulder replacement. And in that situation, what we do is we turn the socket into a ball, and we turn the ball into a socket. And we do that to help stabilize that shoulder a little bit more. Without a rotator cuff, the shoulder is more unstable, and that reverse shoulder replacement is a more constrained or controlled joint. But it's also a little bit more complicated to do that surgery, so we don't want to do that surgery unless we have to.
Mm-hmm. And so what exactly, when you talk about doing that reversal, are you anatomically changing them to reverse their motion, or are you also using implants that are mimicking that but in a reversed way to limit that mobility?
We're using implants. So basically what we do on the socket side is we ream out that socket and then put a tray with screws to hold it into the bone, and then we impact a ball onto that tray. Then on the ball side, we cut off the ball and we put a stem down the shaft of the humerus and attach a cup to that stem. So it sounds more complicated than it is. After you've done it a few times, you know, it makes more sense, and it's but it works very well in complicated, difficult situations.
And so what's the movement or movement limitations like when you're trying to protect rotator cuffs that continue to be damaged? What's the movement like after that surgery on that side as compared to the other?
After a reverse shoulder replacement?
After the reverse shoulder replacement.
What we like to tell patients is that it's more of a pain relieving surgery than a movement increasing surgery, but a lot of chronically torn rotator cuff patients have really no movement of the shoulder, and the reverse oftentimes will give those patients a lot more movement. Basically, what that reverse shoulder replacement does is it recruits the deltoid muscle, which is the big muscle over the side of the shoulder, to act almost like a rotator cuff. And so ideally we would like to see more motion after we put a reverse shoulder replacement in, but it definitely is more consistent as a pain relieving surgery than a motion increasing surgery.
So when you talk about the shallow nature of the shoulder and the ball, does it turn out that more of what you're treating is around the tendons and the ligaments in the shoulder, or do you find you have more degenerative disease in the shoulder bones themselves?
I definitely treat a lot more rotator cuff problems than shoulder arthritis problems. I think if you just went across the board, 65% of people over the age of 65 have rotator cuff tears, so it is a lot more common to see rotator cuff pathology than shoulder arthritis. However, I have started seeing a lot more arthritis because I get a lot of referrals from around central Georgia and South Georgia, and then just from other orthopedists, because not many orthopedists do total shoulder surgery. So early on in my practice, I would say I treated a lot more rotator cuff pathology. Now I am seeing a whole lot of shoulder arthritis and rotator cuff arthritis, or rotator cuff arthropathy, which is arthritis caused by rotator cuff tears.
Maybe living longer also, as people live longer, maybe certainly living longer and are active longer. Maybe.
Yeah, absolutely.
What would you say your advice would be to someone who doesn't have shoulder problems yet or rotator cuff problems? What are prevention and wellness ways to take care of your shoulders and still be active?
I would say, number one, I'm a big believer in fitness, but if you do start fitness programs, make sure that you're having some supervision, especially early on in how you're doing the exercises, to make sure you're not putting undue stress on the shoulders and you're doing the appropriate form for doing shoulder exercises. Number two, I think just doing rotator cuff strengthening exercises that are fairly simple, if you can add that to your fitness routine or just your daily routine, that is one way to keep the rotator cuff strong, and by keeping the rotator cuff strong, you can keep the shoulder from degenerating quicker.
So when you talk about the patients who are referred to you, At what point do you feel like patients should refer themselves to come and see you? Is it a pain threshold? How does someone know if that is what they have done to themselves? Is it an acute thing, or is it just nagging over time that doesn't go away with ibuprofen?
It's both. I mean, you can have a shoulder injury, and if it doesn't feel better in about a week or so after taking anti-inflammatories and ice, you probably need to get it checked out. Oftentimes, though, I would say the majority of my rotator cuff patients are over the age of 65, and they just have degenerative tearing of the rotator cuff, and that can be a little bit more slow, slowly developing that kind of pain. So I would say, I mean, come see me when the shoulder is hurting, and taking some anti-inflammatories or Tylenol or ice hasn't worked for a week or two. I'm happy to see you.
So a final question. If someone comes to your office and say they think they've done something and it's disturbing their sleep and now they need to come and see you, what's a visit like, your progression around identifying shoulder disease? What are some of the things you do before we get to the total replacement or the intervention, surgical intervention?
Yeah, I would say most of my patients, I do get x-rays on all of my patients that come in for shoulder pathology, and that helps us get at least an initial idea of what pathology may be going on. Arthritis does show up just in plain x-rays. But I usually will start with conservative therapy such as anti-inflammatories, cortisone injections, and physical therapy. And I usually give that 6 weeks, 4 to 6 weeks, to see if that works. If it doesn't, then I proceed to get an MRI typically, or a CT scan depending on the patient. But and that helps us look at the soft tissues such as the rotator cuff or the cartilage around the shoulder a little bit better.
All right, well, thank you for telling us so much about your practice.
Thank you.
And thank you for joining us at Atrium Health Navicent Knows Health. If you'd like to know more about Dr. Thomas and his practice in Central Georgia, please visit us at atriumhealthnavicent.org.